We'll just wait a couple of minutes. Thanks. Okay, good afternoon, everybody, and welcome. Thank you for coming. My name's Steve Reed. I'm head of primary healthcare here in the Faculty of Health Sciences. And we've got an interesting afternoon of speakers and discussion lined up. And I'm happy to see you all here. I'm going to ask our interim dean, Professor Carolyn Williamson, to welcome you, and particularly our visitors from other faculties and other parts of the country. And then I'll introduce the speakers one by one and give you some idea of the format. But basically, for the first hour, we are going to have a series of inputs and clarifications. And the second hour, we'd like to give over to you to generate a discussion which we will take into a formal faculty response to the NHI bill. The deadline for that is the 11th of October. So the pressure is on to produce something as a faculty. But let me ask you, Carolyn, to introduce our speakers. Welcome.
Welcome, everyone. All right. So thanks very much, Steve. I just want to give a general welcome to everyone. It's great to have such a full room today. So we're in an important time in our history of health in South Africa. And I'm really looking forward to listening to both the challenges and the opportunities that NHI will bring to us, and just listening to the debate. And so welcome and thanks for coming, and to our other speakers. Thanks, Steve.
So the reason for this forum is that the NHI has been filled with such negativity in the press and a huge amount of criticism, and we have seldom heard much positive about making it work. And if we look at it pragmatically, some form of the NHI is going to happen no matter what. It's got to the stage of a bill, so something is going to happen. Whether that something is something that we all want will depend on our participation in the process. So you will have seen from the wording of the flyer for this forum that we want to put it as positively as possible. And we've got the opportunity to give formal input to the bill in a couple of weeks' time. So that's the purpose of this forum. And the question is, what changes to the NHI bill as has been published would make us confident to support the NHI? And we need to look at it across a number of different aspects. This afternoon, we have 5 speakers lined up, one of whom is not here yet. So I'm going to change the planned order of speakers, but we've invited down from Johannesburg Professor Shabir Musa, who is associated with Wits University and specifically runs a project in Chiawelo, a part of Soweto, where he's successfully piloted a model of care based on the principles of the NHI. He's a family physician and senior clinical lecturer in the Department of Family Medicine at the University of Witwatersrand. And I've asked him specifically to present something of the challenges on the ground of making this work and what he's experienced through his work in Chiawelo. And I look forward to your input. Thank you, Shabir. Thank you.
Thank you very much, Steve, and thank you to all of you and the organizers of this meeting. I think the reason I flew down from Joburg to here and said no problem, Steve, is because I'm struggling to have a constructive conversation in South Africa with anybody. And I thought this is really the kind of thing I really want to be part of, which is being constructive. I think that statement I always like to put up because it says that primary health care is at the core and communities are actually at the core of that in the NHI. And I think we must be careful that it does not as it pans out. I think that Steve asked me to talk about what my take is on the NHI and understanding it. But before I even go on, I am part of this dysfunctional system, which is the public service, and trying to make sense of it and trying to work in Soweto to try and build up a model, yes, within a dysfunctional service, but saying if we were to go into the future, how would we actually do that? And I've been trying for the last 5 years as an ordinary GP family physician in a bit of Soweto to try and model that. Premised largely on a bit of research I did in 2011, exploring how GPs would respond to capitated contracts. And I think this work, it was enough for National Treasury to ask me last year to help develop a contract for the NHI GP capitation as part of the feasibility testing. So in some ways, I'm sharing a little bit of that insight, of all those insights, and I hope you'll benefit from it. I think firstly, lots of us don't even know how the current system works. The National Treasury, in fact, sits there, but National Department of Health is responsible, and I'm just pointing out the lines of authority to province and then to district health service. And that, in fact, the district has direct operational control over various facilities, but that the district is, in fact, a function of province rather than of municipalities. I'm not sure that people know that. So funds actually flow currently from National Treasury, in fact, bypasses National Department of Health and lands up with the provinces. And the provinces then give that out of big budget to wherever they want, and giving a piece of it to health and going down to districts and then to clinics in a budget, line item budget flow. Currently, the governance is that the National Department of Health has various structures like the province, but in fact, provinces are in the National Health Act overseeing a district health service operationally. So in other words, the district is actually part of the current provinces. And district health committees are appointed, which come from local government and from the province, with the chair of it coming from local government. With that body, the District Health Council, having oversight over the district health service. But it can be very nominal, depending on whether it is a province that has a regulated framework for district health council committees to councils to have authority or not. So it can be very variable and depends on the politics as well. So accountability is quite challenged. What the Department of Health is looking at is to create a new structure that is called a District Health Management Office, and it's inserted immediately after the District Health Council. The only change to the current National Health Act in relation to the District Health Council is that this DHMO will in fact have a role to play in the District Health Council appointments, together with the provinces and local governments. So it's only a small material change having that role. But key is that the operational control, so to say, goes to national. So in fact, what happens is that, as I've mentioned before, that's the flow as it goes now. What's going to happen is that national, in fact, is going to appoint directly to the DHMO. So what the current district will happen is that it'll move perhaps to being a body that's accountable not to the provinces, but to national. But that the idea is that that is a body of its own that has a structure that is in the District Health Service in the National Health Act and now in the NHI. What the NHI is going to do is funds won't flow through the provinces anymore to those DHMOs, which don't even receive any funds. Those funds go from the NHI to a new body that's created under supposedly the DHMO. The exact nature of that CUP and DHMO are left in the air right now, with regulations expected to define exactly what that might look like. But technically, this CUP is constituting mostly the current public service clinics. Whether it is in fact a part of the NHI as a purchasing organization, which says contracting, is moot, because lots of people are giving different ideas. Some people related to the NHI says it's part of NHI as a fund, as a purchaser. Others say no, it's actually a grouping of the public service right now, so part of the provider. So I think these are big questions, but in the Act it says that this CUP will contract with private and public providers, including GPs in primary care, and that a CUP is a contracting unit for primary care. Sorry. So the District Health Management Office is tasked at the moment with setting up such CUPs. So there's a huge grayness in that whole terrain as to exactly who is this CUP accountable to and what is its legal status and what will happen. And the bill doesn't give any clarity to that at the moment. So I think what's key is that what is this supposed to be? It's in fact a key principle in the NHI and generally is strategic purchasing. How do you separate the funder from the provider so that you can get efficiencies of direct contracting, which is what is going to happen now? So there's some very positives out of it. One is potentially a very much more decentralized body that's capacitated to receive funds rather than being at the behest of provinces, knowing that, lots of provinces are poorly managed. But that DHMO now is more decentralized and potentially allows the separation of funder and provider, which can get more competition with the private and the public, more involved in actually buying, purchasing, in other words, providing services at a cost. So I think there's possibilities, but whether that DHMO lands up to be no different than a province with all its messes is a key question. So I think those are some of the concerns that might be raised. Sorry. The medical scheme is actually just, in a way, just on the side, currently contracting directly with GPs. The NHI, in a way, I think, in my view, these DHMOs have oversight. A big problem I have is that the DHMOs are, in fact, looking at 50 bodies in the country as opposed to 9 provinces, and supposedly being able to contract directly with providers. And a lot of that problem is capacity. And in effect, by saying these CUPs will be set up, is saying current districts and sub-district managers will be tasked to actually manage contracting besides providing care. So I think whether they're contracting only or providing care and subcontracting is a big question. But I think there's huge capacity issues. So in my view, a real problem that needs to be dealt with is that the NHI should, at provincial level, be actually doing that contracting for now, at least. And then as time goes on, think about just how the public service actually gets reorganized into becoming a clearly independent provider, even if it's publicly owned, to be able to then contract in competition with other providers, which might be not only GPs, but other organizations as one goes along. In time, you might get a situation which is that you have a district level CUPs. In other words, the purchasing actually gets decentralized further at a district level. And I think the reason that this is really important, that we don't jump in and start setting up structures that become difficult, is that really to get the kind of NHI happening, which is efficient and cost effective, we need some really strong professional accountability and some really innovative purchasing approaches, which is value-based contracting, capitation, or alternative reimbursement models. And you need that to be coming together slowly and not rushing it, because a lot of it's very highly dependent on whether the providers are ready as well as the purchasers, and that is not going to happen in one shot. So I think that is the kind of space that the government has to really reset healthcare in terms of the purchasing provision environment. In my view, as a family physician, I come from the perspective, and this is the kind of work that I did with National Treasuries, to share an idea of how bottom up, instead of being overly top down, is to allow a system to come from the bottom, which is very much having a strong sense of professional accountability, as well as based on capitation with some elements, mixed capitation, that would allow people to actually be much more responsive to patients. Yes, decentralization is good, but whether that will transform to be really patient responsive is a key question. I've seen districts that are very rigid, that have a bureaucratic approach. I've seen that you need to actually devolve it even further. And the suggestion that I made was, in fact, that we move towards a community practice, which is an enrolled panel. In most parts of the world, panels belonging to GPs or teams of care are between 1 and 3,500. This is a very unusual number, but it's possible in South Africa, largely because of the fact that it's got to be team-based. So enrolling a population between 2 and 10,000 with that minimum growing over years to about 6,000 is important, but it's strongly premised on being community oriented, that it's about understanding populations, not just treating patients, being able to understand how they use the service of the facilities, engaging with key stakeholders in that population, and then being able to get targeted health promotion. Without that, costs will simply be a replication of the inefficiency in the private sector. And we need NHI to work for everybody well. So this is very important. I think the package of services is no more than looking at the current clinic and adding a doctor and looking at the range with the team that will be able to provide to that population and progressively grow. I've actually suggested that it can be done with using the guidelines as a base, that's the audited guidelines, and looking at the PHC elements of them and beginning to actually just layer them a little bit clearer, but not necessarily to try and fix every dot every I and cross every T. But that in effect, service packages are actually defined not by a list of conditions, but what it is you have to treat them. Because the knowledge varies, but the actual resource you have of the lab test and the medicine, these define packages more than a list. So in my view, that's the kind of thing that needs to be developed, and with different payment systems, mostly capitation, but including a fee for service to drive certain behaviors like family planning, etc., and pay for performance because of the fact that accountability needs to come along, although it needs to be sensitive to the clinical environment. And I think this can actually be improved over time with the National Institute of Clinical Excellence that should be developed in South Africa. I think there are a few slides and I'll be finished, is essentially there are key elements of this contracting. One, it must be strongly based on teamwork. So doctors should be encouraged not to think they will deliver all the care. There's nurses, there's clinical associates, and in fact encourage clinical community health workers as part of the way to think. That includes community orientation, that they don't think of it as just a silly thing. It's actually critical to building up a way to prevent and promote and manage care in community. And this is the buzz in all over the world. How do you actually reduce costs through that? The third thing is that you need to actually think about how you support the referral. Referrals are actually part of the moral hazard, is that in capitation systems, people pass on the risk to higher levels of care. You need to manage that, but in a peer review approach, how do you actually build that in? And that can be done. The fourth one is that the DHMO needs to coordinate, and there needs to be a structured relationship between any practice of 10,000 people and the district. And then you need to actually allow space to innovate in this environment. Operationally, there's the question of accreditation. It's not very difficult. Currently, the ID clinic manual is there. So any provider, GP clinic, can in fact go through those processes. And I think that the two processes need to become one. And that is on the table of the minister. That says this, that you have the right kind of qualifications. I think certification in the bill is now from the Office of Health Standards Compliance. It's actually certification we're talking about, but accreditation simply the NHI fund saying, yes, you're suitable, you're contract worthy. Enrollment is, in fact, something that's very important, that people will be enrolled. People will be offered the opportunity, people to say, who do I go by? Here's a list within the district. How can I choose? And it's not very difficult to arrange it. It is a big problem. Enrollment takes time, but it needs to be very careful. One of the challenges in the bill, it says providers will actually do the registration, which is a huge problem. Enrollment and registration are two different things. This is about enrollment. Data submission, importantly, is that we need to actually collect data, and that even though we don't have EHRs that are robust at the moment, we need to move towards that. And it is possible to collect data even with simple payment management systems. Peer review is part of that support system broadly. I think it's about ensuring that we develop ways in which professionalism is encouraged, and so we don't have you have to understand how clinicians can be able to understand managing resources and supported in managing resources rather than administrative people doing managed care. And this is the clear environment. Almost done. I think training, family medicine training and the diploma is actually very important, and we think that will support clinicians to actually move in that direction. This is the contract which we put together with all these addenda that were handed over, and I think it basically allows an opportunity for the NHI fund to literally get on with contracting GPs, as an example, and primary healthcare services very easily, provided there's a clear legal, in the public service, clear legal entity that's being dealt with, which could be a district. So anyway, there's a couple of other suggestions here, which I'm sure they'll take note of, but I'm sure that that can be part of the equation. So let me stop there. Thanks.
I'm going to rush people a bit through their talks because we've got 10 minutes each. But quickly, are there any queries of clarification for Shabir before we move on? Okay. We had invited Dr. Melvin Moodley.
He sends his apologies.
Ah, okay. I didn't receive those. All right. That means we can relax a little bit with regard to the time. So I'm going to ask my colleague, Professor Sue Cleary, to talk about the money side of things. She's from the Health Economics Unit, and she's one of the coordinators of this forum. So Sue, over to you. Whoops.
That's it, yeah. Good afternoon, everybody, and thank you so much for being here today. We really do appreciate your participation and your engagement in this issue. So the NHI is obviously there's a really large number of reforms in there, and so I'm going to speak very specifically just to the one aspect of it, which is the aspect that I know best about, which is the economics. So I'm going to focus on what is the theory of universal health coverage and the economics aspects of that. How is this then applied within the NHI, and what are the gaps or problems from my perspective? So I think we all know, but it's worthwhile remembering what it is that we're talking about here, which is that we want to provide all people with access to needed health services that have to be of a sufficient quality to actually work, and also to ensure that this does not impose any financial hardship. So the two goals, therefore, are access when in need and financial risk protection. And this framework from Joe Cutson, I think, is very useful for trying to visualize and understand a bit better what we're talking about. So on the left-hand side in the blue are the health financing arrangements to do with revenue collection, pooling, purchasing, and the benefits, which is what I'm mainly going to be talking about. And then in the middle, in the purple, you have these intermediate objectives that, if achieved, should help you to reach the goals, which are what we already mentioned in terms of equity, quality, and financial risk protection. So starting first with revenue collection, in the NHI, as we all know, the plan is that there'll be a central fund, and that the money for this fund will include the provincial equitable shares and some of the conditional grants, not all of them. And it will largely be a matter of using existing taxation approaches in order to, but the main difference is the money is going to be pooled centrally. In the appendix of the NHI bill, it says that the conditional grants to be shifted to the fund potentially include the National Tertiary Services Grant, which is of relevance to us who teach in the Faculty of Health Sciences, as well as the HIV/AIDS and TB grants. And it's not clear at the moment how the money will be shifted, but that's the current plan. If we move then to pooling and purchasing, the plan is obviously to pool all the resources and to actively purchase from providers that are accredited. And finally, just moving on to the benefits. So I just wanted to outline those two bits because otherwise my talk doesn't really make sense. But my focus is on the benefit package. So firstly, in terms of who are we talking about, Chapter 2 defines the population to be covered. And I think some of us would have concerns about foreign nationals not being included there, but nevertheless, what it is at the moment is all citizens, permanent residents, refugees, and prisoners. And it basically outlines, it's actually quite a beautiful thing. I think we have to say it's amazing to see such a large emphasis being placed on the achievement of horizontal equity. And so users have a right to receive quality services free at the point of use, to know what the services are that they're entitled to receive. So a lot of information they're entitled to have. They have a right to be referred or transferred if needed. And if a service is refused, they have a right to know why. So that's an extremely powerful set of entitlements. So what does this then mean? And this thing is called the UHC cube, and what it seeks to unpack is these 3 dimensions of who is covered, which services, how much is the co-payment. And in the current public system, we can't say for sure, but approximately 80% of the population is covered. And in NHI, the idea is to move to 100%. In terms of whether the services are free at the point of use, in the current public system, there are some user fees, but it's largely for hospital services and it's largely for higher income people. But within the NHI, all services will be free at the point of use. And so that means that the only dimension that is left to play with is the dimension of what are the services. In the current public system, the package of services is largely implicit, meaning it's not written down as a clear list of entitlements as is envisaged within the Act. And it is largely, therefore, inequitable, meaning that there'll be differences in terms of where the people can get those services and where they can get those services. Whereas within the NHI, it's going to be explicit, in other words, clearly defined as a list, in theory. And this, I think, is one of the few ways that you can achieve horizontal equity. So just to summarize so far, in the current public system, the rationing of benefits is largely implicit. It's achieved through poor quality of care, long waiting times, and what is known as horizontal inequity, meaning different people have access to different things with the same condition. And within the NHI, it will be explicit, and if done well, this can be extremely good for social capital. If done poorly, I'm not sure. So it's an extremely long list, possibly defined through standard treatment guidelines, essential medicines lists, and similar. And that obviously we're talking about things that must be safe and efficacious. They need to be of quality. They need to be available equitably. They could or could not be cost effective. That's not necessarily 100% required, as well as a whole bunch of other reasons why you might want services. So just to clarify some of these terms from an economics perspective, if we're talking horizontal equity, what this actually means is that we seek to equalize benefits subject to whatever constraint you are able to model, normally a budget constraint, but other constraints can be included as well, and subject to equal treatment for equal need. And it's possible to program all of this mathematically, and quality is always captured within the cost functions. If you want to be cost effective, it's still a maximization. It is a maximization now, but not necessarily subject to equal treatment. It's possible to be cost effective and equitable. And now it's a maximization, so with the efficiency in there, as long as it's equitable. Okay, but that's all quite confusing to understand, so I've put a figure together that's hopefully a little bit easier. So what we've got is the height of the bars is the cost effectiveness. So the higher the bar, the more cost effective the program is. And the width of the bars is the budget impact, so how much it's going to cost to provide it equitably to everybody in need. And the budget basically then determines the last service that can be provided. And as you can see, the budget actually intersects in this example with a package, meaning that last package, if you cared about equity, couldn't be part of the benefit package. So what then happens if we want to consider new things? So here are two new candidates. These are more cost effective than a number of the current technologies. And here are another 2 candidates, which are less cost effective than all the current technologies, but are more effective. You don't consider the ones that are not effective. So that's the first thing we would need to let go of. But if you start considering the ones that are cost effective, the very important thing that happens is you start having to replace certain services. This is known as disinvestment. And it's a very difficult thing to do well, and is often done implicitly without actually considering where you're getting the money from. If, however, you do manage to do this thing, you're going to gain population health to the tune of the shaded yellow area. So it can actually, cost effectiveness can be very important if you want to maximize, but it's absolutely essential to consider cost if you want to be equitable. So the important points is that equity has to be defined in relation to the constraints. It doesn't mean anything if we don't know what the budget constraint is or the other constraints. If we program for cost effectiveness, we will also increase population level outcomes. So equity and efficiency work together. It is a misconception to say that there's an equity efficiency trade-off. It is not the case. They work together. It's effectiveness that we trade off against. So will we be able to be happy to no longer create programs or policies based on things that are awesome for the individual, but that are not necessarily affordable? And then the final thing is it's really hard to be explicit about your disinvestments. So beyond the algorithm, obviously you can't just mathematically program your health services. There has to be a process, which is normally within a procedural justice process, because reasonable people are going to disagree about these things, and they ought to disagree about these things. So it has to be thought about quite carefully. And this is just an example of a kind of process that's often used within health systems. It's called accountability for reasonableness. Okay, so how is this actually happening in the NHI? So in Chapter 7, there's a number of advisory committees that are to be established by the minister. One of the important ones is the Benefits Advisory Committee, and it's very much doing things in consultation with the minister. And this is the committee that basically decides a lot of the stuff that's going to be provided within the NHI. There's also a Healthcare Benefits Pricing Committee that's to determine the prices. And then again, within the fund itself, so now not under the minister, but within the fund, there's a very similar kind of a body that's going to do very similar kinds of things. So this is what it looks like. And these are the things that are supposed to be done. And these are the areas of overlap. And in addition, the minister is allowed to deviate from the benefit package for reasons that are not yet determined. So for me, what's really important here is that I want us to commit to equity, actually. So if we do this, if we commit to equity and quality and free care at the point of use, then the only way for us to keep the fund solvent is to ensure that the benefits package is affordable, or to not have an explicit benefits package, or to continually adjust the benefits package. You could also, in theory, continually change prices, but I think that that could be a very bad strategy. What's also important to me is I think it's unclear whether we will, and I'd say we meaning actually academics, whether we will be prepared to trade off individual effectiveness in order to achieve population equity. And I also think that we haven't got any track record at all at the moment of having an explicit disinvestment strategy where we say, in order to do this new thing that we think is so important, we're going to stop doing all of these other things, and these are the people that are going to be affected by it, and that's what we need to actually have. What's missing is there is no clear statement of adherence to budget within the bill, and I think that should be in Chapter 2. At the moment in Chapter 11, it says that there are a number of regulations that can be created, including to do with the nature and level of reserves to be kept within the fund. I think that that should be in there now. What's very problematic is that the minister is mentioned 140 times. I would not want to be the minister. Imagine the responsibility. Imagine the workload. But basically, the bill enables political decision-making, including of some extremely, extremely technical things. I'm not sure that even the cleverest actuary in South Africa knows how to do these things at the moment. So I think it's a big problem, all this political decision-making. In conclusion, a commitment to horizontal equity actually does require us to be explicit about what we're going to offer, which is extremely exciting in some ways. But in practice, a hugely difficult political and technical exercise, and I think, if not done well, extremely risky. For me, the key aspects of the bill that have to be changed are, it has to say that spending will be within budget. There has to be a sort of rationalization of the number of times that the minister is allowed to decide things. And there has to be better alignment of decision-making institutions. Thanks.
Before you leave, Sue, are there any questions of clarity for Sue before we continue? Great. You were crystal clear, obviously. Thanks, Sue.
I'm sure I wasn't.
It was clear enough to me that we have a finite envelope of resources and we have to plan within those. So thanks, Sue, for making that clear. I'm going to move on to our next speaker, who is Dr. Gitesh Solanki, a health economist and senior specialist scientist at the MRC. And we've asked him to talk about the role of medical aid schemes in the NHI. And we look forward to your input, Gitesh. Thank you.
So just to say, I really struggled to put this presentation together. I mean, there's obviously a conflict of interest here in terms of the public and the private. I mean, so I'm going to start off with, my presentation is I'm going to do a disclosure in terms of my personal conflicts in terms of the medical aid scheme and what happens to medical aid scheme. And then I'm going to contextualize kind of the way medical aid schemes go within the NHI, what is NHI trying to achieve, and why medical aid schemes represent a problem for NHI. I'll then take you through the specifics of the NHI bill on the medical aid schemes, and then the issue of what I'd like to see changed in terms of a fully implemented NHI, and then also the transition phase as we get to NHI. And then lastly, kind of the broader concerns. So starting off with the disclosure, and I'm sure everybody here is a member of a medical aid scheme. And the question is, how does one look at the public interests? And obviously the public interest is saying we will want an NHI where everybody has access to universal healthcare versus what most of us as medical aid scheme members have. I mean, so you've got a system which, as faulty as it is, you're paying for the system because it's offering some value to you. And the question is, how does one kind of balance between the two? So this, in struggling with it, I mean, I know it might come across as quite a reactionary presentation in some way, but I then ended up saying I need to get somebody's view on this. So I spoke to a longtime colleague of mine, Dr. Jude Canal, who's sitting at the back, and said, hey, listen, what I'm presenting reasonable or not? And she gave me her endorsement, so I'm going to go through the presentation. So starting off, I mean, in terms of NHI, what is I mean, everybody now knows the goal of NHI is to achieve universal healthcare, and I'm not going to go through the definition. What is the problem that it's trying to address? The key problem to universal healthcare in South Africa, the way NHI has been formulated, is that we've got two healthcare systems. One is public and the one is private. And this creates barriers to access to healthcare and coverage. And then the key one is the fragmented funding and risk pools, because we've got a public funding system and then we've got a whole range of private systems which each individual medical aid scheme represents. So the solution has been framed, I mean, is the creation of an integrated risk pool, that we need to take all the medical aid, the money that's there, public and private, put it into one risk pool. And the NHI fund then becomes a single payer, and there's economies of scale and power that comes with a monopoly buyer that will then buy services for the country as a whole. The obvious implication of that is that to the extent medical aid schemes fragment funding and risk and the risk pool. So you have fragmentation both in terms of contributions, because you as an individual medical aid scheme member pay to your medical scheme, and there's multiple medical aid schemes, so each one is a different fund. And then there's the public sector side. And then on the risk side, I mean, you belong to a scheme that has its own risk pool, and each medical scheme has a different risk pool. So you fragmented the risk pool as well as the funding pool. So if one wants to create both on a unified system and bring all the risk together as well as all the funding together, I mean, almost by definition, the role of medical schemes should be either eliminated or minimized. So, I mean, that's the context. I mean, there's a natural implication of the strategy that's been adopted by NHI. So if one goes then to the details of what does the NHI say about medical aid schemes, and I mean, looking through the bill as it currently stands, there's only one clause that speaks to medical aid schemes, and that's clause 33, which says, once NHI has been implemented as determined by the minister through regulations in the Gazette, medical schemes may only offer complementary cover to services not reimbursable by the fund. That's the NHI. So that's the only clause that speaks to medical aid schemes within the National Health Bill. And then obviously the key issue here is that medical schemes can only provide complementary cover once it's been fully implemented. Medical schemes may only provide complementary cover. And the definition of complementary cover in the bill is basically any services not covered by the NHI. So, I mean, effectively, whatever is determined, if it's fully implemented in all the services that the NHI covers, what is left is what can be covered by private medical schemes. Right? So, my concerns with this then come, the first one is what is a fully implemented determination? It's a major decision with far-reaching implications, and as defined, it's very open. And one could argue from both the left and the right that what becomes a fully implemented NHI is very difficult to determine, especially if you don't have any criteria or a process for determining that. I mean, so at which point will we say that NHI is now fully implemented? When based on the level of services that are covered, on who is covered, what costs are covered, access, quality issues. I mean, there's no definitions as to how one is going to decide what is fully implemented. If you take that kind of this logical conclusion, it means that we'll never have a fully implemented NHI. Or the minister could tomorrow or in a year's time decide we've now got a fully implemented NHI and all medical schemes must disappear. And it's a pretty open-ended clause in the bill, and that's of concern. I mean, I personally would like to see have some ideas to what criteria are going to be used. The second issue, and obviously it's quite linked to it, is will this be a progressive determination or a once-off determination? So will we start implementing the processes of the NHI, and at some point in time say, right now we fully implemented and medical schemes must disappear? Or do we say NHI is now 50% implemented, either in terms of people covered, in terms of the services that are covered, and progressively then kind of reduce the role of medical aid schemes? So said again, it's not clear based on the way it's defined. The other part of it, so obviously firstly is what are the criteria we're going to use to define what's fully implemented. The second is the process. I mean, if we don't define what the criteria, and it's not opened or clearly understood up front as to what the criteria, then surely we should have a process which allows participation over and above just the Minister of Health at some point deciding that NHI is now fully implemented. So I think those two kind of go together. And for me personally, I mean, I would like to see a lot more clarity in terms of how this is put together. The definition of complementary, and this is kind of the reactionary part of the whole thing. But if NHI is a strategy to consolidate the risk pools and to enhance income and risk cross subsidies. So there's a whole set of processes. We're going to take away the medical aid subsidies. We're going to increase taxes. We're going to have additional taxes, etc. So you through that process, one assumes that there will be a lot more cross-subsidization that happens. The question is, after all of those funding reforms, I mean, this is a question I know I've had, or debate I've had with Jaya, is if after the funding reforms where you've now maximized the income cross subsidies, if an individual wants to purchase private cover, why not? And I mean, I haven't looked at the evidence. I haven't done the research to say. So I'm saying right now you have 50% private funding, 50% public funding. If after funding reforms you get to 90% private funding, or you've increased your public funding so much more, is it absolute prerequisite that everybody has to be in the NHI environment? I mean, then this creates, a whole lot of legal issues that could come down the line. I think it would make things a lot more difficult to implement if you don't have that kind of escape or promise of an escape for people to say, listen, if you pay your extra money, you pay your NHI taxes and everything else, you've raised the funding for the public sector. But at the end of the day, if you want to have private cover, you can have it. And it's a debate one can have. I personally haven't seen the evidence to say why everybody has to be in one system and why can't people have an exit system. The second part of the thing, so that's kind of the end state of NHI. The question then is what happens along the road. The earlier versions of the bill, especially the white paper, spelled out in quite detail what would happen to medical aid schemes as we go from the current state to the end state. The current version is silent. I mean, there's absolutely nothing in the bill that says what changes are going to be made and how they're going to be changed, how those changes are going to be made. A lot of the powers are given to the minister to pass regulation, and one can only imagine that the minister will just regulate to make the changes as it goes along. But as I said, in terms of the document as it currently stands, there isn't any clarity. So the question is, what are the plans for medical aid in the transition phase, and what approach will be used? Right? So currently, I mean, I envisage that there could be three approaches that could be used, going forward. So the current approach for medical aid schemes, what I call is a neglect approach. Essentially, if one looks at the medical scheme environment since 1998, when the Medical Schemes Act was implemented, and especially in recent times, there's almost this waiting on NHI. So basically, everything has been stopped. There isn't, and the Health Market Inquiry kind of picked up on this as well, that there's been almost regulatory stasis, although there's been now a medical schemes amendment bill that was passed. But by and large, key issues like the prescribed minimum benefits, tariffs, pricing, etc., everything has been on hold on the understanding that NHI will kind of supersede and take over everything. So what's the point of reforming the private sector if NHI is going to take over everything? That's kind of your neglect approach. The second one is what I call the shut down approach. So in the earlier paper, the NHI white paper, there was very clear plans, almost an active management approach to say we're going to consolidate, implement a set of active reforms with the aim of consolidating the medical scheme environment and eventually collapsing that to NHI. And that one would call it kind of the active shutdown approach. And the third one is kind of what has come out of the Health Market Inquiry, which says, listen, there might be a longer time horizon there might be quite a long time horizon before NHI is fully implemented. And in that period, then we should look at reforming both the regulatory side on the funding side as well as the supplier or the provider side, with a view to addressing some of the issues that are there so that the whole system becomes a lot more sustainable. And that would be the kind of the what I'd call the manage approach. In terms of the bill, as I said, it's silent. And these are all three approaches that can be taken. I'm not sure which one they're planning to go with. And then the last area is kind of the taking the concerns, and I think of medical scheme members more broadly, and that's my private concern as opposed to the public concern. There are 8 million people in South Africa who are covered by medical schemes. They are generally of higher income, but they are across all race groups. It's the notion that it's only a white thing is quite inaccurate. If one looks at the household survey, the membership of medical schemes now spans across all racial groups. And ultimately, the question is that 8 million people in this country have joined medical aid schemes because they found public funded services do not meet their needs. I mean, it's not people who are contributing because they want to just donate money. I mean, the fact of the matter is that these members, either mandated by their employers or individually, take out medical cover because they're not being, for whatever reason, the public services is not meeting their needs. Right? The second part then is the context of the reforms. I mean, everybody knows all the issues of the state, and broadly that we're living in a country with limited state capacity and a low level of trust. I mean, so that's the second one. So then if one puts those two together, then the question that comes to mind is, does the NHI policy initiative represent a jump from the frying pan into the fire? I mean, are we going from a system which is half working or barely working into a system where nothing's going to be working in the future? And I think that's a concern. I mean, that maybe people haven't expressed, so it's been politically just kind of shut down. But I think it's a concern that I experience in my kind of working environment. I work with a lot of medical aid schemes, and I mean, that this is a concern that people express. It's a concern also shared by, I think, providers, a lot of providers. And it's a concern, I mean, if you take the middle class in a country, that I think one has to, somewhere along the line, recognize that there are these concerns. So my thing then, again, on terms of the NHI bill, would be to ask the powers to be, to say, appreciate the concerns and started by addressing the misunderstanding and lack of information. People don't understand what is NHI. I mean, at the end of the day, even in this audience, I think a lot of people, we don't really know what NHI is going to be. And I think we need to start unpacking very clearly to say, in an NHI environment, where will I get my primary healthcare? Do I have to get authorization? Will I be able to go to whoever? I mean, I think those are kind of very practical things that need to be explained to people, because the debates that are taking place are at a fairly high theoretical level, which the lay people don't understand. And then I think the last kind of point I would say is we need to learn from the lessons. I mean, that we have. OBE is a classic example where very well-intentioned policies were implemented in a context which wasn't ready for it. And I think we need to kind of learn from some of the failures of the past and take them into going into the NHI environment, because I think NHI is a big, big policy initiative. I mean, it's one of the biggest that we're going to take over the next while. And if we don't learn from the past and just move ahead, because it seems to be the right thing to do, I think we could end up replicating a lot of the errors of the past. Thanks.
Thanks very much, Gitesh. Any questions of clarity for Gitesh before we move on? Okay, thanks very much for that. You almost exceeded your mandate there, because I asked you to address what would make NHI work as opposed to what would make NHI fail. So we'll see how we proceed with the last speaker, who's been sitting very patiently up in the right-hand corner of our screen, who is Sasha Stevenson. She's a lawyer and works for Section 27, which is a non-profit organization based in Johannesburg, dedicated to the upholding of Chapter 27 of the Constitution, which deals with health. Marlon, are you going to do the necessary IT thing here? But Sasha, welcome. Thank you for joining us. You're going to need to unmute your mic, and Marlon's going to hopefully show us your slides. Or you haven't got slides?
I don't have slides.
Oh, great. Okay, so we'll look at your image there.
Version of my head.
Yeah, perfect. Thank you. So welcome, Sasha, and thank you for your time. I'm sorry you couldn't join us here in person, but I'm glad that you could join us by video conference. Over to you.
Thanks so much. And I'm sorry from my side that I couldn't join you in person, but it's been great to listen to other presentations. And I've been asked to deal with quite a range of issues. I'm going to be looking at legislation and phasing and, oh, that's better, thanks. and I just look at myself, legislation and phasing and ongoing learning and the roles of various role players. And so I'm going to try and give some a couple of concerns, but mostly some suggestions, and I'd love to hear feedback on them because these are obviously all kind of works in progress. So firstly, on the legislation and the phasing and the ongoing learning aspect, I think starting with an act, starting with a piece of legislation, inevitably makes learning and development quite difficult. And because it's by necessity a top-down act, it assumes that we know what we want in the end, and we know all of the details of how we're going to get there right up front. And so that is problematic in itself. It also doesn't allow us to deal with some of the people stuff, some of the relational issues, some of the process of change that's so important in instituting big change of any kind. So that's one of the downsides of starting with the bill, but here we are having to make comment on this bill, so we do what we can. I think what's also relevant to note is that the phasing that's currently provided for in the bill provides for 2 phases from now. It's now until 2022 and then 2022 to 2026. And essentially in the first phase of the bill, the now until 2022, it provides for pretty much everything. Everything's going to happen in the first phase. And then the second phase is we're going to carry on doing everything, health system strengthening, etc. We're going to mobilize additional resources, so that means more taxes, really. And we're going to selectively contract from private providers. So we're really front-loaded, I think, in our implementation, which isn't really phasing. And we've been pretending to phase in NHI over the last 10 years while not really doing that. So the phasing that's currently provided for in the bill, I think is difficult, and what's strange and also difficult is that it's different to what the minister and his team keeps talking about in terms of implementation of NHI. So they're talking about a much longer process of development and implementation, a more iterative process. Those kinds of things. So those need to be legislated because they're going to be funded. We can't leave them out. We might need to legislate who is covered, and I agree with, I think it was Susan who raised concerns about population coverage. I think that's going to be a big problem, and I hope will be changed. What we also need to legislate is processes for deciding what is covered and other decision-making processes. So we need to know how decisions are going to be made. We need to lay those out in the bill or in the act. We also need to know what changes will be required to current structures and current role players with the establishment of the fund. So if there's going to be changes to the roles of the minister and the national department and the provincial department, etc., that needs to be laid out now, given that there's a new player in town. And then, and I'm going to talk to this a bit more, we really need to legislate the requirements of inclusivity and participation. Those kinds of things can be put into a bill and are sufficiently implemented. One of the things I don't think that we actually need to legislate now are some of the structures that we don't entirely know the role of. So Musa was talking earlier about the district health management officers and the CAPs. Those are structures that are described a bit, but their real role isn't really delved into. And it may well be that the way that we're seeing them now won't make sense when we've started the rollout of NHI. So I don't know that we really need to be legislating details around those structures now. I also don't know that we need to be legislating payment mechanisms. At the moment it says things like hospitals will be funded based on a global budget or DRGs. That's not really the way to legislate, to say there are various options, but we're including them within a piece of legislation. So if we're going to be testing out things, we need to be giving ourselves space to test out those things. And when you legislate in requirements, it closes that space. So some of my suggestions then for phasing and implementation of the bill, I think we need to suggest leaving out the components that don't actually need to be legislated for starting the process of implementation of NHI. We also need to be very explicit in the bill, and I think we can do this, we can create wording this way, about learning and piloting and development. We can say that it's important that different interventions, different initiatives get tested, and that there's a process of monitoring and evaluation along the way. That should be built into the bill, because then it's required that we're actually considering different options, seeing what works best, what doesn't work. I think the other thing that we desperately need to be explicit about is the requirement for participation and transparency. One of the things that has one of the lessons that have been learned in other countries trying to implement universal health coverage is that things like contracts that are signed between government and service providers and other kind of agreements need to be made public, so that there can be some public analysis and assessment. That transparency provides for accountability. And participation in the various structures of users, of civil society, of academia is really important, both to ensure buy-in and to make sure that the right decisions are being made. So that needs to be included in the bill. Also, what needs to be included in the bill is a direct reference to bodies whose role is stewardship and capacitation of other structures. So if the national and provincial departments of health are supposed to be providing capacity, are supposed to be developing other structures, are supposed to be providing or playing a stewardship role of the health system at various levels, that needs to be provided for explicitly in the bill, so that we can get that kind of supportive system that allows the change in healthcare system load in the structures. And then finally, I think we need to include in the bill a process for developing any structures, any new structures or interventions that need to be established depending on what works. So rather than saying we're going to have CAPs and DHMOs and provincial offices that are management agencies and various different cost centers, there needs to be included in it a process for development of those things. So that's some of the phased implementation suggestions that I would make. And then finally, on the roles of different structures that are put forward by the bill. I'm not going to talk about the DHMOs and the CUPs, but I think others have said there's, so I'll talk about a little bit about the fund and the various structures around the fund. Others have said that there's a lot of centralization to the minister at the moment. I haven't counted how many times he's mentioned, but the fact that he appoints an ad hoc committee which interviews and then appoints board members, he then appoints all of the board members, he appoints the chairperson of the board, he appoints the CEO of the fund, he appoints all of the committees of the fund. Just doesn't make sense for accountability purposes. So my suggestion would be this. Firstly, if you're going to have an ad hoc committee that interviews and makes recommendations, that ad hoc committee should be established to be representative. We already have structures like this. For example, the Judicial Services Commission. I wouldn't suggest something that's quite as political as that, but I think things like including academia, including civil society, including user groups in the structure that receives nominations, which must be a public process, that holds the interviews for board members, which must also be a public process, and then makes recommendations to the Minister for appointment of board members. That allows for more transparency and more participation in the establishment of the governance structure of the fund. The board then should be accountable not to the minister, but should be accountable to Parliament. It's not perfect by any stretch, but ordinarily within the Public Finance Management Act, if you have these kinds of boards, they're accountable to Parliament because that's supposed to be all of our representatives. So that needs to change as well, because it's accountable to the member. Then the board should be the structure to appoint the CEO. That's the way that it ordinarily works in companies and organizations, and it allows, again, there not to be too close link between the minister and the CEO of the fund. And then I think also we need to be clearer in the requirements for membership, for appointment and removal of people on the board. So at the moment it just says they need to have some kind of qualifications, and there's a couple of things that are laid out, and they need to be a fit-for person, etc. I think what the De La Ona Institute has their research on state-owned enterprises has shown is that it works much better if you're much clearer about some of the qualities, some of the skills and capacities of potential board members, and that you're clear that this isn't a political appointment, because that's where we really have seen we run into problems. And then again, there needs to be clear on provisions for removal. And then there's the committees, and there's the Benefits Advisory Committee, the Pricing Committee, and the Stakeholder Advisory Group. So the Stakeholder Advisory Group at the moment is very unclear. No one really knows what they're going to be doing. It just seems to be a sop to all of us who are involved, that at least you're part of some committee. That needs to be given a clearer mandate and role. And then the other committees, the Benefits Advisory Committee and the Health Products, whatever it's called, Pricing Committee, at the moment it says that they are appointed by the minister after consultation with the board. Now, after consultation just requires that he speaks to the board and then he can do whatever he likes. I think it makes more sense that they're appointed in consultation with the board, because they are structures that are assisting the board in fulfilling their mandates in various ways, and that those committees then appoint their own chairpersons. So that's kind of my basic suggestions for creating both an accountability structure in the board of the fund, and then also broader health systems wide accountability to ensure that there are sort of watchdog bodies built into the structures of NHI. I'll leave it there.
Thank you, Sasha. That was very clear from a legal perspective, and all these considerations to take into account. I'm just sorry that our other speaker, Melvin Moodley, couldn't give us some insight into what we asked him to give us some feedback from the Eden district pilot, which was the pilot in the Western Cape, and the role of the provinces. But maybe there's someone in the audience who could give that perspective. What have we learned over the last 5 years from the pilot sites around the country, and how has that changed things? But I think all four speakers have been very clear from their different perspectives. And now it's over to you to ask questions or make your comments. Sasha, I wonder if you could just mute your mic when you're not speaking, but you'll have to wave your hand if you want to say something, and I'll see if I can pick you up. I've asked two people specifically to prepare to respond to the speakers, just to get the discussion going. So I'm going to ask Andrew Bull, where are you, to come up and give your perspective on things. And when people are speaking from the floor, if you could use a microphone, because this session is being recorded and live streamed, so we do need you to speak into the mic. Andrew.
Thanks, Steve, and thanks to all the presenters. I've learned a lot, and it's a very constructive discussion, as these NHI discussions have played out. I'm going to be quite strident, and I hope it's not in the spirit, against the spirit of this meeting, which is based on being constructive. But I feel politically conned, because I remember the debates to build social and economic rights into the Constitution. I remember the lead up to the Health Act, and Shabir wrote this fantastic article in the Daily Maverick, which laid out the district health system as a cornerstone of a pro-poor health system. it made a lot of sense to me. We were building on best practice. We were laying out a health system that involved decentralization, primary care, and a public sector-driven health service. I admit there's implicit rationing as Sue said, in a public sector health service, and I'm sure there's a lot of efficiencies that could be gained. But right now I'm seeing a critique of what has gone before as being anti-poor, and that NHI is pro-poor. For me, it's the opposite. I see massive risks to the poor people of this country from an inefficient health system that's commodity-driven, commodified, with supply-induced demand driving up the costs. Currently, it's 6 times as much per beneficiary in the private sector as in the public sector. If we even halved the cost in the private sector and made that the average cost, we'd be increasing the total health budget by 50%. An extra 250 billion rand a year taken away from economic development for this country on an industry that's not going to massively improve well-being necessarily, where a lot of the determinants of health are not from curative healthcare. And then from an accountability perspective, I remember the attempt to try and make healthcare a local authority, a local government-driven or local government sphere-driven enterprise. We just didn't have the capacity in local government, and the provinces ended up holding the services until the local government could strengthen. But it was always envisaged that that there would be a sphere of government that was accountable for these services. What I've seen in what's being proposed is the removal of all accountability except for this national office. It's going to be like healthcare is district offices of a national entity, and we've just heard Sasha telling us the extent of massive political control of that national entity that's going to drive our health services. I really don't see how we're going to get accountability in what's being proposed. Susan said, if not done well, extremely risky, and Gitesh said, are we going from the frying pan into the fire? As a progressive academic community, we have been incredibly silent about the risks to the most marginalized in this country in our acquiescence to these proposals. And I've tried to work out why we're so accepting, and I think it's our collective abhorrence of inequity. There is such massive inequity between the private and the public sector. A lot of what's being discussed is how to fix the private sector, and we're going to destroy the public sector in the process. And not enough about how do we defend the small gains that we've made in the public sector, the coherence that we have in the public sector. And so what are some of those risks? So I work in the provincial health department. I cannot imagine our department functioning without our central hospitals, without being able to run an ambulance service provincially, without being able to implicitly redirect and re-ration as things change on the ground, and without being able to make a budget stretch as far as we possibly can, without the risk of suppliers making claims on that budget because of their personal gain and interest. So I think there's a massive risk of inflation, of fragmentation, and I've mentioned the risk of the cost structure of the entire enterprise going through the roof because of supply and just demand. Looking at what's happened since the Medical Schemes Amendment Act, which has completely failed to rein in any costs in the private sector. And then there's the how. How do you reform such a massive industry? Do you do a pilot? And everyone hates the word pilot. Then maybe replicate it locally, and then maybe learn your lessons, and then try again, replicate again, then feel you've got a good implementation model, and then start a commission about how you could reform your whole system using those lessons from an implementation model? Or do you come up with an act? So Sasha was talking about starting top down and reform the entire system with proposals that nobody really understands how they're going to work. So I think from an implementation perspective, we've got it completely the wrong way around. And as a community of people in the academic sector should be protecting the marginalized, we should be, from an academic perspective, saying that's not how you do healthcare reform. You do not start with an act that absolutely pulls the rug out from under the functioning health services. And I realize we're in the privileged position that some of our health services in the Western Cape do function, and that for people in provinces where stuff functions so incredibly badly, they're willing to throw caution to the wind. But I really think the risks are much greater than we perceive. How it could very likely play out is that the fragmentation happens. We lose our central hospitals, we fragment our coherence, And then we run into a problem where we actually cannot afford an acceptable benefit package. And the people who have to make the decisions about that, what did you call it, taking away benefits, disinvestments, are people like us and the politicians who are all on medical aids, who have had 20 years of becoming accustomed to a certain type of benefit that they are not going to agree politically to have taken away. And so the political elite will never agree to those removals of benefits, and we're going to stall. So we're going to break the system, and then we won't have enough money to make it work properly, and we won't have the political will to drive through the unpopular decisions. So I think we have to, from an implementation science perspective, we have to be very, very cautious about a reform of this size with these levels of risks. So to try and be a little bit proactive and constructive. So I really like the idea of the community practice. I mean, I think it's what we're all aspiring to, even in all the obsession in our province at the moment with community-orientated primary care and community health workers. The cleavage point is that there's no link between the fixed facilities and the community, and I think, Steve, you've spoken to that before. And the community practice that was all-encompassing with a dependent population. What in the current Health Act makes that impossible? What is wrong with the current Health Act that makes it not possible to run a community practice? And strategic purchasing. What in the current dispensation makes it not possible for us to use like the tender system for drugs, to use the economies of scale and the purchasing ability that the public sector has to get value, to prevent us from doing cost accounting in the public sector so that we can actually look at efficiency, to measure equity, to implement approaches to drive equity. So I think it is possible to take the notion of capitation, the notion of community practice, and implement it in the current public sector environment, and to move to much more cost accounting and drivers of efficiency. And in the private sector, what stops us implementing all of these ideas about benefit packages and risk pooling in the current private sector without risking our very treasured public sector where it does work? Thank you.
Thanks, Andrew. That sounded like a very prepared speech, but you did respond to the others. And thanks for your final, more constructive comments. The other person I've asked to respond is Lydia Cairncross from the Department of Surgery. But there may be others in the audience who are bursting to say something. But in the meantime, Lydia, could you give your perspective? Thanks.
Thanks, Steve. I have to just say that I'm not speaking on behalf of the Department of Surgery. These are my personal views. So thanks for asking me to make some comments. And I come to the NHI debate from a slightly sort of different angle, because I've run a number of community workshops around NHI and spoken at different events. And I think that, I've looked at the various iterations of the NHI, all the way from the green paper, the white paper, through to the draft of the bill last year to this year. And what's clear to me is that NHI is contested terrain. It's a politically and economically contested terrain. And every iteration of the document looks slightly different depending on what that balance of forces looks like. And in a sense, that is, for me, a measure of hope, because it means that there is space for us to try and bring within the plan, and I share many of your concerns, into the plan some of the pro-public sector policies that we want, and some of the safety accountability measures that we want to see implemented. So I'm just going to focus, and I think all of us are probably on the same page in this audience, that we're starting from a premise that fundamental change in the health sector is essential. It's critical and it's long overdue. Both the public and the private sector are in deep and ever deepening crisis, and we need an intervention. Is the NHI the correct intervention? I think it's debatable, but it's the intervention that's on the table. And I think there's enough space within the plan for us to try and fight for positive policies and changes within it. So I'm going to focus on really three areas that I think are critical. I think we should, as public sector health workers and as academics, be asking at every single forum on NHI, what is happening to the accreditation of public facilities? So the Office of Health Standards Compliance report showed that only 5 out of 696 facilities reached the benchmark of accreditation. This makes NHI completely irrelevant to the public sector if the plan is going to be implemented in 2026. So one of the things that's positive that I think we can leverage out of the political mileage around NHI is we want to see NHI, but it only makes any sense, it only has any meaning if the public sector is in a position to benefit from this fund. I mean, let's be honest, at the moment, the fund is really the public health budget. There isn't anything else there. But I think what we need to position is that discussion, and the elephant in the room is what is happening to the upgrading and accrediting of public facilities. If we do not do that, if and when NHI is implemented, the private sector is going to essentially have a massive market, and the public sector is not going to benefit. So for me, Parliament should be putting that question at every single sitting. How many facilities are now accredited? We have to maintain the integrity and the accountability of the Office of Health Standards Compliance, of course, but I think it's something that we should benchmark and be asking what is happening to accreditation. So that's the first point. The second point is I understand, over time I've come to understand the need for the provider purchaser split, because we need to find a way to touch the private sector. At the moment, the private sector in this country is the biggest in the world. It's the most powerful proportionally. And we don't have a way to break into that, I think, without shifting how we purchase services. So for the first time in this bill, this very last iteration of the bill, there is a direct statement around what will happen to medical aid schemes. There's been a lot of rumor and conjecture, but Clause 33 for the first time states it very clearly, how the NHI proposal is going to decrease the power of the medical aid schemes. But what is not clear to me is how is it going to reduce the power of the private hospital groups and the private providers. I'm not talking about GPs or even individual specialists, but I'm talking about the private health industry. So the two possible scenarios is that the NHI is powerful, well-organized and efficient, and the public sector has been upgraded. And when we're purchasing in a capacitated way. The private sector gets smaller and smaller and the public sector grows. Another possible scenario is that the public sector does not have capacity, the private sector does, and we outsource a large number of our services to the private sector. If that happens, we essentially will decapacitate what we have in the public sector, and we may further undermine what we currently have. This is very dangerous. And I think that interface of purchasing from private providers, particularly within the hospital groups and particularly amongst private specialists, to a lesser extent, I think at a primary healthcare level, is really important. So we need to work into the bill some kind of regulatory mechanism so that we have a pro-public sector NHI. It's not just about equal competition between two health systems. It isn't. They're not equal. We have to have a fundamentally upfront stated pro-public sector perspective on this. So we need to capacitate as far as possible and make sure that public can provide first. If the public sector cannot provide and we need a private provider, how is that relationship regulated? How is that relationship used to build capacity in the public sector? And how long does that relationship continue? There needs to be regulation on that. Otherwise, we have the potential of using up all the money within a space of a few years. So the interface between private and public is absolutely critical. And in my view, we should say we don't accredit any private hospital until every single public facility has been upgraded and accredited. We don't want to rush into an NHI where we say, let's, as an emergency, outsource and purchase from private, and we haven't allowed our public sector to catch up or allowed that capacity to grow. So that's my second point. And my last point is how can we as academics impact on what is going to be within NHI? So we know that there are these very powerful subcommittees of the board that are going to be established. And I think the Benefits Advisory Committee is an absolutely critical committee. So the history of health policy with our Department of Health is not one of very democratic participation in my experience. So like the Ministerial Advisory Committees, they're individuals that are appointed, they don't have accountability to structures, and they often are secret in that they can't reveal their conversations. So I believe the Benefits Advisory Committee should be open. The participation should be not only from a select group from the board, but should include professional colleges, societies, health science faculties, various professionals, community groups, health committees representing facilities, and that every single individual that is on that committee must be accountable to a structure. We need to know who to speak to, and they need to know who to report back to on what they are deciding about what our healthcare system is going to look like. So if we can use these committees as a way to try to democratize the health system so that we shift the power from being just these kind of secret board-appointed committees to actual public participatory committees, I think there may be an opportunity there. Thank you.
Thanks very much, Lydia. I'm looking for hands from the audience, and if you could find a microphone, that would help. What we've heard from Shabir is some ideas from the ground, as it were, from a practice perspective in Soweto. We've heard from Sue about the funding, and we've heard from Gitesh about regulating the existing private sector, and from Sasha the legal aspects of the structures and the processes to establish those structures, which are so important. And then Andrew reminded us of the politics of this, the political context of this bill, and Lydia again is reminding us of the need to upgrade the current existing public sector as a precondition. So that's what's been presented very briefly so far, and we're really interested in your input. So Ishak and somebody else have the other mic? Yeah, Maylene.
Okay. Thank you. I think this has been very informative, and I just want to build on some of what has been said. Just to say that from a philosophical perspective, I fully support the ideals of the NHI, but from what I've heard before, I am quite concerned about a few things, and I just want to say that I think that building on from what Andrew said, we need to consider that any intervention that we implement in healthcare, we usually only implement it on a broad scale when we have enough evidence. And I'm very concerned that we haven't produced the evidence to be able to implement an intervention of this scale without having shown how we can make it work effectively. And perhaps we need to consider a full-on pilot, not just at a district level, but going all the way, kind of a pilot of all the structures from national down to district level, and look at kind of slices of pilots within the different provinces to see how it can work, because each province is a different context, and that's what we need to consider. My other concern is that at the moment, all we are looking at is funding biomedical interventions, and we are not addressing the social determinants of health. And if we are really wanting to address equity, we can't just be addressing access. We need to look at the other aspects of social determinants of health, and that needs to be funded. And I'm not clear from the bill. Health promotion, for example, how is that going to be funded? But all the other kind of addresses, interventions dealing with the social determinants of health, those need to be spelled out very clearly, and that needs to be part of the pilot, I think.
Thanks, Ishak. Maylene.
Thank you, Steve. I think Ishak just reiterated the same concerns that I had around social determinants. I won't say anything about that. But I think there's lots to say about two aspects, I think. One of the more successful countries that we often turn to as an example, Thailand, which went from, I think, a position where their health indices and so on are significantly poorer than some of ours, had taken about a 40-year period to build themselves up in very successive, very deliberate, well-supported politically and otherwise phases to get themselves to the point where they are at. So firstly, I think we need to shift our minds around the time frames that we're setting for ourselves, and that we need to give adequate and ample time for such a major project and a major restructuring process to take place. And to build on what Lydia had said, for example, that we don't move to the next phase until we've achieved a particular aspect of our work. The second point that I want to raise, and you started off the discussion, Steve, by speaking about the fear that's being instilled. So I think one of the fundamental aspects when such major policy reform is afoot, it's absolutely fundamentally important the kind of messages that gets put out. And so far, the messages, and Andrew is right, had been dominated by people that are fearful of giving up their private sector privileges and potentially having to turn to the public sector for their care. So I think, I mean, Gitesh is sitting next to me, there's very little empirical evidence to suggest that the quality of care in the private sector is any better than the quality of care in the public sector. There's lots of anecdotal evidence, and I think any one of us could give a long list of examples of ourselves, relatives, friends, that have actually received poor and inefficient quality of care in the private sector. So that's one of the suggestions that I have, that we really need to work on the messaging of what this reform is all about. The second, the same, I think, applies to inefficiencies in the private sector, etc. And Gitesh, in fact, has one of the few empirical studies that speak to the significant inefficiencies in the private sector around cesarean section rates that are astronomically high, that speak to really poor quality of care. So, and then the other aspect I think that is important for me is to build on the notion that that there is evidence, and there is a class issue here at play very, very strongly, that where the middle classes rub shoulders with the working class and the indigent in the same queue for social services, that the voice of the middle class, and whether we like that or not, has particular, I think, capital in a society such as ours, and that those voices can actually elevate the quality of care in those social services. So by keeping the middle class confined to a private sector, we're actually also robbing ourselves of the opportunity to contribute to the elevation of public sector care and public social services for the entire society, notwithstanding the fact that I do have difficulties with the middle class being privileged to certain environments anyway. But I think there is a social capital there that would be brought into raising the quality of care in the public sector.
Absolutely. Behind you, Maylene. Your reference to cesarean section rates makes me think of Brazil, where in effect their primary care system has been run now for 20 years by government, and their specialists have retreated to the hospital sector and receive referrals from the primary care system on a fee-for-service basis. And so there are these two systems, and their cesarean section rate is something like 70%. So there are dangers there.
I just want to underline a couple of points. Maylene has already raised these. So one of them is about the messages. And I think that so far, the understanding of what NHI is in the public and actually amongst politicians, I'd say, is extremely vague. I think that there are many, many people who, if you actually got them to really spell out what they thought, they would probably say, it means free medical aid. It means I don't have to pay Discovery anymore. I'll pay something, quite a lot less, but I'll get what I'm getting now. And so that misapprehension really has to be dispelled. I understand that we're talking about positive messages. I find it fairly hard to have positive messages about NHI because of the level of confusion that there is. I also think that I was interested in the point that Maylene raised about taking 40 years in Thailand. And we're talking about a situation where there was low or minimal private insurance. and introducing NHI in a system where you have an incredibly powerful private health funding arrangement is an absolutely different kettle of fish. You have really, really powerful voices against NHI, enormous vested interests, who will, as I think a number of people have said, the danger is, and I think that Lydia mentioned this as well, the danger is that people in the private sector will position themselves to run things. We've already heard that, we can administer, we should be the administrators. And I think that the point that Lydia made about not accrediting any private hospitals until all the public hospitals had been accredited is a very powerful one. I think, though, that there is a massive public education task ahead. I mean, I do wonder, and it's a point that I've raised with Gitesh earlier, I wonder if you went to Parliament and said to the members of Parliament, do you realise that with the current situation, that in a couple of years, PALMED will be no more? Your benefits under PALMED will disappear. I wonder if you would have people actually voting for the NHI bill.
Okay, thank you for that. So, I mean, a communication strategy and rollout is absolutely crucial. And the level of confusion and negativity driven by the media is very significant. Are there other comments or questions, Leslie?
Thanks very much. So I was really struck by Gitesh's comments because the original green paper of the NHI made it quite clear that the way the system would work would be that the real costs of private healthcare would gradually be transferred to people in the private sector as users. In other words, our medical aid tax benefits would be rolled back. So you would actually carry the real costs of private healthcare. But the way the bill is currently operating, I mean, that's still unclear. So I think it's one thing to force people into an NHI package. It's another thing to say, well, actually, if the real cost of your package were to be borne out of your pocket, you might choose to go to a well-functioning public health service. So those are the two sides that seem to have been lost. So maybe that's a message we should be emphasizing, that in fact, the first pilot should have been to gradually decrease the medical aid subsidy, and actually people would experience what it really costs to use private healthcare and make a decision. Well, actually, I can get good quality healthcare in the public sector if I'm vociferous enough to make sure those posts are filled, and the managers, do what needs to be done to make sure it's an efficient system. So maybe that's also an argument that we should be making.
Thanks, Lizzie. Graham?
Thank you, Steve. I mean, just quickly to pick up on Leslie's point, I remember Di McIntyre in one of her talks saying, and Sue can correct me, that I think 30% of the spend in the private sector comes from out-of-pocket expenses. People are not on private medical schemes, and that if those people moved over to the public sector when the quality improves, and that's a big assumption, the private sector will contract. And what I remember saying is, we can just leave them to their own devices. They will fast find out that they either have to be more efficient or they have to consolidate. But I think what I'm missing is a need for the emphasis on measuring and the importance of primary care delivery. And in Sue's presentation, Sue, in your axis going from funding to operations to outcomes, I mean, I'm thinking of the Primary Healthcare Performance Initiative's conceptual framework, which has systems, inputs, then service delivery, which really describes cost-effective, person-centered primary care, people-centered primary care, and then outputs and outcomes. And I don't see that, and I don't hear enough or anything about that. And it comes to what Andrew was saying. I think that if we start delivering good, cost-effective primary care, which is measurable with validated instruments, and as it turns out, most of the work in Africa has actually been done in this province measuring cost-effective primary care using validated tools, then we will get better value for the money. And if I understood Andrew correctly, but there's no legislation against doing that. If we did what we know is right to do, we will get better quality and people will come over, we get better health outcomes because the outcomes improve, the costs go down, and the disparities actually reduce with that kind of evidence-based primary care.
Thanks, Graham. Any further contributions from the floor? Yeah, go ahead.
Just one small point. I hope I haven't left anybody with the impression that I like the private sector. That's absolutely not the case. It's more to do with long experience of entirely how powerful it is, and also how aspirational it is to people. And I just wanted to point out that about 20 years ago, Gitesh and I and another colleague were contracted by the Minister of Health to do a piece of work on readiness and ability to pay for social health insurance, national health insurance. And we did that piece of work, and the outcome was absolutely clear. I mean, it was frighteningly clear. People said we would pay if the quality was improved, but we won't pay and hope that and believe that you'll improve the quality afterwards. First show us the quality, then we'll pay. And there was quite a strong support for the idea of prepayment, so not paying, fee for service, so paying via a payroll tax, etc. The minister said thanks very much, and then completely ignored this piece of work.
Yeah, thanks.
I just wanted to follow on a little bit from what Lydia said. I'm also a surgeon. If you consider the private and public healthcare, I accept that a lot of public healthcare facilities are not good. But if you consider specifically in tertiary hospitals, a lot of the time the care that patients get is of a higher standard than what patients get in private healthcare settings, and that's something that's not always appreciated when in these discussions. And I think if you're considering pilot projects going forward, one needs to consider certain aspects, and specifically in surgery, there's certain things that would be quite easy to roll out. And I think when discussing some of these things, it's important to, I think, rather than consider private versus public, consider the actual quality of care that people get. So a good example, I think, would be, for instance, trauma care. If you consider Cape Town, there's no real level 1 trauma units in the private healthcare setting. Patients get taken to hospitals where sometimes there's not even a surgeon on call, there's no blood bank, there's no neurosurgeon. And if you wanted to roll out a pilot project, why not start off saying we're going to set up NHI, where all patients involved in serious trauma in a certain city go to 1 or 2 specific trauma units that are well funded and well resourced, and you set minimum requirements that have to be set. And there's lots of other examples of if you consider what I do about biliary surgery, it's very clear that high volume units have better outcomes,
more efficient,
and that's the way that these things have been implemented in lots of countries around the world. People go somewhere and have a Whipple's done by a surgeon who does 2 a year, your mortality rate is going to be much higher. So certain things will be much better done in high volume centers, and it's going to be easier to set those up in a NHI system that's centralized and academic in a way.
Absolutely. Thanks for that. And there's a article also in the Daily Maverick by Tim Tucker around the NHLS, which was very convincing about the economies of scale with regard to lab tests and the ideal platform that the NHLS presents. Unfortunately, Tim couldn't be here today, but it was a very convincing perspective, also in the Daily Maverick. Virginia.
Thanks, Steve.
Is it on?
Thanks, Steve.
There we go. It's a pleasure.
The province, the only message I can really bring from the province is this provincial Department of Health is very concerned about the vanishing power and stewardship about the department. This has been a very effective, it believes that it's a very effective provincial Department of Health. I don't think we would make comment about other provincial departments of health, but this one has been. And for example, in the pilot, you asked about the pilot, the one thing that I know about it is that when there was contracting of GPs, it worked well when the province was involved, when the district was involved and the province was involved. But when the National Department of Health, through the NHI pilots, contracted directly with GPs, it was a fiasco. So that really makes the case for the importance of having a functional provincial department that is closer to districts, for the districts to interface directly with national. 52, I mean, how feasible is that? So we really need some checks and balances, something that what Andrew put forward about the absence of that. As far as Lydia is concerned, some of the points that she made, I'm concerned also about the capacitation of the public sector. What are we saying about that? We don't have enough referral institutions to send women with breast cancer. They have to go directly to Groote Schuur or to Tygerberg for the entire province. Only certifying certain facilities is not enough. We actually need to build capacity in district hospitals, in regional hospitals with enough expertise that is able to manage the full range of problems that people have. We cannot be transferring patients from George to Groote Schuur for treatment. And what are the alternatives? And so we really need a better plan for investigations, for therapy, and so on for important conditions. Thanks.
Thanks, Virginia. Catherine?
Thanks, Steve. I just had a question, and I think I asked you this at the provincial meeting, but just to say that, it seems like it's a big black box as to what the benefits of this proposed NHI bill is. And I think if we don't actually specifically know what we're talking about, it's very hard to know how to implement and roll out benefits. And I think that when Andrew was sort of suggesting perhaps to do a pilot, I'm just also wondering, in terms of phases, if there could be a minimum package of benefits that the NHI is trying, because it's all being run centrally. And I think there are concerns that, it's much more effective decentralized. But, I don't want the surgical side to be overrepresented, but I'm also a surgeon. And, often the surgery gets a bad reputation of being not cost effective. And, perhaps when you're talking about disinvestments, where will that compromise be? And where's the research that's being done to show what procedures, what tests, what services are more cost effective, and then the whole equity piece. But perhaps since we're talking about community-based models, perhaps we should just try to roll out a preventative package for everyone that's just based on a few benefits for everyone, and try that rather than having a giant package that we don't have a lot of inputs for.
So we're supposed to have had a 5-year piloting phase since 2013. And the evidence from that piloting phase is very scant. I had hoped that Melvin Moodley would talk to the experiences from the Eden district, but they have had some success in the GP contracting in terms of, and some lessons learned. I think the qualitative things have been the most instructive, but we haven't got that to be presented today. I'm going to ask for a few more comments, and then I'm going to turn it back to our speakers just to close off one by one if you've got some closing comments. But Arne, go ahead.
I just want to see, are there any journalists here? Because quite frankly, I can't blame the media for saying confusion or reporting confusion, because I found myself agreeing with almost everything that was said today. And that makes me very confused, because half of it is contradicting the other half. Just as an example, the NHI, as I see it, is essentially an exercise to increase resources in the healthcare service and distributed it more equitably. On the one hand, we have our current health services where the argument is that if we increase resources, will it really improve the quality of service? And we've seen a lot of examples where that hasn't been the case. And then on the other hand, you have the comment that the private healthcare sector isn't any better, even though it's spending, what Andrew says, 6 times more per person. So just that message is already very confusing. And then just now you brought up the point of evidence, and we're in the School of Public Health. What actually works? And I think we have a unique opportunity here, whether we agree with what's going to happen or not, it's happening. But we really need to do some consensus building about what works already and how do we protect that, and what opportunities there are there to improve what is already working or add new things that are working. And this whole concept of disinvestment, it sounds like a bad word, but we should somehow get the messaging across that disinvestment is actually a good thing because it helps more people than it disadvantages.
Thank you, Arne. I'm going to go back to our speakers. Any other comments? Yeah, last 2, 3, and then we'll go back to rounding off.
David Murray, I'm coming into this discussion from 3 points of view. Somebody with a clinical background, somebody with a laboratory background, and somebody who's retiring and who might well need medical services. The fundamental thing is, I think we all agree that healthcare is not great. And for me, especially not in the more severe metabolic conditions. And you might say that that's similar to the plight of surgeons with more severe conditions. And we're constrained really by a large load on the system that is avoidable. So in this whole deal, I don't see how we're going to curb the demands that social change or stresses place on the medical services. And I think there's a responsibility from people who draw from those services not to do unnecessary demands on the services. And some people who believe in the medical aids being much better will think they're losing the freedom of determining their health care after they've paid their general tax to put the public service there, and then the special payment for the medical schemes. So that's, for me, a very difficult problem, and I'm not sure what the solution is, but certainly we need to look at something that's going to make that better. But for me, the biggest problem is the kind of conditions I deal with, and they really belong to tertiary centers. Not spotting those. So firstly, individuals who come through primary health care with those problems deserve a proper diagnosis from which to make the most rational decisions for using limited resources. And not making the right diagnosis can waste resources, never mind the suffering and deaths that ensue. And I haven't learned from this where the responsibility lies with litigation if something does go wrong. And how you will debate whether resources should have been allocated more in the direction of specialized treatment or general treatment. That's difficult.
When someone has refused a drug that they need. Or,
yes.
Yeah.
And what I also see in this is that the current system, the NHLS has not provided for the development of tertiary services at all. And I would think that the universities are the only remaining part from which to rebuild such expertise to be relevant to the population, because in the private sector, those services, because they don't pay, are not available. And while genetics is popular, the chemistry is not receiving the support it should. And that should be slick and quick, and that should be integrated into the service in general, with reasonable support for proper diagnoses. Not necessarily highest technology, but there are some older, cheaper tests that can make an immense difference to lives in this country.
Thanks, David. Behind you, Teresa, and then Ishak, and then we'll go back to our speakers.
So I came in very late, apologies, but I was in another meeting around community-based workers. And I've checked with some colleagues, and very little has come up about rehabilitation. And I think it's a problem that this faculty really needs to recognize. And at the Dean candidate's presentation, there was talk about using clinicians and health economists. What has been done on the National Health insurance so far has zero almost on rehab. And so maybe the suggestion can be that we have a forum focused on that, because there's very good evidence. And I'm not sure you spoke on the community-based models, but from our Klipfontein sub-district, the therapists there have excellent evidence of the difference it's making.
Thanks, Therese. Ishak, last one.
Quick question to Prof. Musa to perhaps elaborate a bit more on the capitation model, COPC, what's the capitation model that you're using, and in terms of what outcomes have you been experiencing, both in terms of strengths and challenges?
Excellent. Thanks. I'll give you a chance in a minute, Shabir, because I'm going to start with you, Sasha, in Johannesburg. If you can turn your mic back on. If you've got any closing comments to make to anything that's been raised so far.
Yeah, thanks, Steve. Just very briefly, I think, there's been a lot of discussion in the questions and comments about the evidence problems, about the lack of clear evidence and the lack of agreement on the evidence that's there. I think one of the important points that should be made by the faculty is the need for transparency in relation to the evidence that's available and in relation to any testing of interventions. Because someone referred to research that's previously been done. There's been so much research done that's been hidden from everybody other than a couple of people within the department. And as a university, a health sciences institution, I think it's important that point gets made. And also the point about participation and inclusion in particular of academia and faculties of health sciences in the various structures and decision-making bodies, so that any decision made can be more evidence-based. I'm afraid I'm going to have to leave the call now because I've got another meeting at 4 o'clock.
Sure.
Thank you.
Sasha, thanks for your participation. We really appreciate it. Thanks. Bye-bye. I'm going to go to Gitesh. Would you like to make any closing comments there? Behind you is the mic.
Just to say that my brief was specifically to speak around medical aid schemes, but I agree with Andrew and the comments made by Lydia that the big danger of NHI as it's currently being formulated is for the public sector as a provider. I mean, I work with medical aid schemes. In medical schemes, some of them do use state as a provider, and the capacity of the state hospitals to contract with funders is declining over a period of time. And if one kind of transposes the NHI environment and the capacity of state currently to contract with the NHI fund, it's poor, and it's going to take a long time to come up to speed. So the real danger right now is if we implement NHI really quickly, without strengthening the state and its capacity to contract, I think we could almost destroy the public sector as a provider.
So the timing and the phasing is absolutely crucial. Shabir, do you want to come up and answer that specific question and any other comments?
Yeah, I just want to say I think it's been very useful. I think that the comments that Sasha shared about going about this bill and stripping out unnecessary detail is actually a very useful one. I think that needs to be brought home to that committee. But I think that if we have to look at how we go about things, and I think in some ways people are saying, no, let's not tinker with the public service by allowing the private sector in. And I share the sense that, one doesn't want to have an unbridled, unregulated system. But the NHI represents actually a very strongly regulated system that deals with the difficulty that our constitution protects a lot of openness that the NHI will be able to deal with within a closed system that's there. But if you're looking at the public service has had the last 25 years to actually do stuff. And in primary care particularly, I don't think we realize just how much of waste is going on. How many of you realize that, in fact, 47% of our budget, the total health budget, is actually spent in primary health care in this country? Not many. If you look at the costs, we've actually established, this is numbers that you can easily look at the DHB of the last edition. The current per person visit in South Africa, per visit in South Africa, is 450 Rand per visit. Whether it's a nurse or a doctor or a drop in the mouth by somebody who may even be a community health worker, every visit costs 450 Rand. We actually did some numbers in this capitation work with the government, and it turns out that the price point between the public service currently, stripped of everything a multidisciplinary to contain only the clinical elements of a doctor-nurse team, amounts to about 900 plus minus. But that in fact in the public-private sector, the only partly capitated scheme is about 1,100 Rand. I don't want to give you exact numbers, but that's the kind of price point difference, which is very small. If you're looking at how do you actually then get care, and this is a private sector GP care. It has its challenges, but it's an equivalence. When we looked at, well, how do we add on multidisciplinary team? It turned out that just dental care alone, based on the private sector, was exactly that same amount. So if government were to provide dental care in the using the current numbers, it would be twice the amount it spends on primary care, which would suck up the entire budget of health in just providing dental care added on to that doctor-nurse based primary care. So I think there's clear need for a lot more work to be done. But I think there's a clear problem that the public service is very inefficient. And I think that strategic purchasing needs to be there to try and create competition. That doesn't mean you abandon the public service. It's there, you need to support it. But I think the last 5 years and 10 years have been evidence that government is failing to actually deliver on managers' better management. And I mean, that's across the country, not the Western Cape.
Thanks. I'm wondering if you want to make any closing comments, Sue? Yeah.
I just wanted to say thank you so much to everybody for some really wise, insightful, and constructive comments. It was really, really great to have such a enabling discussion about this really important policy. So thank you so much for coming.
Yeah.
And importantly, thank you so much to Joe Hunter-Adams, who's sitting over there, taking notes furiously, and the notes that she takes will be transformed into the first draft of the faculty input. So Joe, thank you so much for your assistance. It would have otherwise been a nightmare of transcribing and horrible things. So thank you, Joe.
So thank you, everybody, for coming, and particular thanks to Shabir Musa for traveling from Joburg to be with us, and to all our speakers, Gitesh, Sasha, who's left us, Sue, yourself. Thank you. And Lydia.